Welcome to the deep dive. Today we're plunging into sarcoidosis. It's a condition maybe not everyone's familiar with, but it really highlights how interconnected our bodies are.
Absolutely. It's a fascinating sort of systemic inflammatory puzzle.
And that's our mission today, isn't it? To piece together a clear, memorable picture for you.
Exactly. We're not just listing facts. We want to navigate the details of sarcoidosis from what it is to how it's managed.
Giving you that solid understanding.
Right. We know your time's valuable, so we're really focusing on the high-yield stuff here.
Okay, let's dive in then. What exactly is sarcoidosis?
Okay. So at its core, sarcoidosis is a chronic inflammatory condition.
Chronic inflammation.
Yeah, and the key feature is the formation of these tiny clumps of immune cells. They're called granulomas.
Granulomas, like little roadblocks.
That's a good way to think of it, yeah. Little roadblocks of inflammation popping up where they shouldn't. And the most common places are the lungs and the lymph nodes.
Lungs and lymph nodes. So the respiratory system mainly. But you said elsewhere too.
Oh, definitely.
Yeah.
These granulomas, they can also affect the skin, the eyes, the heart, even the nervous system.
Wow. And the cause?
Well, that's the real head scratcher. We still don't actually know what kicks off this whole inflammatory process.
Huh. Like the immune system just sort of malfunctions?
Kind of, yeah. A bit of a mystery malfunction, which, as you can imagine, makes diagnosis pretty tricky.
Right. If there's no single cause, how do doctors figure it out?
Well, it's not straightforward. There's no single definitive test. Diagnosis is usually about putting together the whole picture.
The clinical picture.
Exactly. What symptoms the patient has, what we see on imaging, like a chest x-ray,
Okay.
and crucially, ruling out other conditions that could look similar. That differential diagnosis process is key.
Process of elimination. Got it. And the notes mention different ways it can show up initially, something called Lofgren syndrome.
Yes. Lofgren syndrome, that's a classic acute presentation. Think sudden onset.
Acute.
It's often remembered by a triad of things. First, erythema nodosum, those are painful red bumps, usually on the shins.
Right.
Second, bilateral hilar lymphadenopathy.
Right.
That means enlarged lymph nodes you'd see on a chest x-ray, right in the center.
Okay, enlarged nodes.
And then often fever and arthralgia joint pain, especially in the ankles.
So bumps, nodes, fever, joint pain.
Exactly. There's a mnemonic sometimes used. LFO, erythema, lymphadenopathy, fever, arthralgia. Helps remember Lofgren's.
ELFA. Nice. Good memory hook. What if it's not that sudden Lofgren's presentation?
Right, so in contrast, you can have chronic sarcoidosis, which develops more gradually.
Slower onset.
Yeah. In those cases, we might see things like persistently elevated levels of serum ACE in the blood.
ECE?
Angiotensin-converting enzyme, it's often high. And if we take a biopsy from an affected tissue, we'd see those characteristic non-caseating granulomas, those clusters of cells, but without central cell death or necrosis.
Non-caseating. Important detail.
Very. And also, it tends to show up more in young adults, usually between their 20s and 40s. And interestingly, it's a bit more common in women.
Okay, so 20s, 40s, more women. Got it.
Yeah.
That covers the what's. Now let's tackle the why, the etiology. What do we actually know?
Right. Well, this is where it gets complex. Despite a lot of research, the precise cause is still unknown.
Still a mystery.
Pretty much. What we think is going on is a complex interplay of a few factors.
Like what?
Well, first, there seems to be a genetic predisposition. Some people might just inherit genes that make them more susceptible.
Okay, genetics.
Second, environmental factors are almost certainly involved. Exposure to certain things.
Airborne stuff, maybe?
Possibly, yeah. Airborne substances, maybe infectious agents. And third, there's definitely an abnormal immune response happening. The body's defenses get triggered in a sort of over-the-top way.
So it's like a combination lock, genes, environment, immune response, all have to line up.
That's a really good analogy, actually. Researchers are looking at different theories. Maybe an infection, a virus or bacteria kicks it off. Or maybe exposure to certain substances, perhaps occupational ones. But no single trigger has been definitively proven yet.
No smoking gun.
Okay.
So who's most at risk then? Are there specific risk factors?
Well, it can affect anyone, really, regardless of age, race, or gender. But we do see it more often in certain groups. People with African or Scandinavian heritage seem to have a higher prevalence.
African or Scandinavian? Interesting.
And as we said, that typical age of onset is between 20 and 40.
Right.
So those are the main demographics where it's more common.
So family roots in those areas in that age bracket, slightly higher chance.
Potentially, yes. And we do sometimes see familial links, which again points back to that genetic component.
Makes sense.
And there's also some suggestion, though it needs more research, that certain occupations might carry a slightly higher risk, like firefighters, maybe healthcare workers.
Interesting. Okay, so the immune system is overreacting. Let's get into the pathophysiology. What's happening at the cellular level with these granulomas?
So the core issue is this exaggerated immune reaction. For reasons we don't fully understand, the immune system launches this really intense response, which leads to the formation of those abnormal granulomas in different organs.
And what are they made of, these granulomas?
They're mainly clusters of a specific type of immune cell called CD4 plus T lymphocytes. They just kind of group together.
Like a little inflammatory huddle.
Exactly.
Yeah.
A persistent inflammatory huddle. And when these granulomas infiltrate tissues,
They cause problems.
right, they cause inflammation and they disrupt the normal structure and function of whatever tissue or organ they're in.
Okay, but the initial trigger for that immune response, still fuzzy.
Still not completely understood. The triggers, the exact step-by-step process of how the granulomas form, those are still big areas of active research. We see the result, the granulomas, but not the initial spark, clearly.
Right, okay. Now, because it can show up in so many ways and affect different organs, it sounds like ruling other things out is crucial, the differential diagnosis.
Absolutely critical. The symptoms can mimic so many other conditions, so a really thorough differential diagnosis is essential.
And what you consider depends on the patient.
Exactly. It depends on their specific symptoms, which organs seem affected, their age, their ethnicity, even travel history sometimes. It's like medical detective work.
Considering all the suspects, so what's on that list? What conditions often get confused with sarcoidosis?
It's quite a broad list. We need to think about other inflammatory conditions like rheumatoid arthritis,
Okay.
various types of lymphoma cancers of the lymphatic system, metastatic malignancy, meaning cancer that's spread.
Right.
Tuberculosis is a big one because it also causes granulomas, though typically caseating ones.
Ah, the case-eating difference again.
Yes. Then there's multiple sclerosis if neurological symptoms are present, lung cancer, other interstitial lung diseases like intrahepatic pulmonary fibrosis, even things like systemic lupus erythematosus or SLE,
Right.
multiple myeloma, and another one called eosinophilic granulomatosis with polyangiitis or EGPA.
Wow. That's a lot to rule out. Really shows how varied the presentation can be.
It really does.
Okay, let's zoom out a bit. Epidemiology. How common is this and where do we see it most?
Well, the incidence varies quite a bit globally. Here in the UK, it's considered relatively rare, about 16 new cases per 100,000 people per year.
Okay, 16 per 100,000 in the UK.
But interestingly, it's more prevalent in people of African or Caribbean descent living in the UK.
Right, we mentioned that risk factor. What about worldwide?
The global variation is even more striking. You see very low rates in places like South Korea, Taiwan, Japan, maybe 1 to 5 per 100,000.
Really low.
But then much higher rates in countries like Sweden and Canada. We're talking maybe 140 to 160 per 100,000 there.
Huge difference. Sweden and Canada much higher.
Yeah. And again, it most commonly affects adults under 50. And while most cases just pop up sporadically, we do see familial clustering in about, say, 4 to 10% of cases, which again hints at genetics.
That geographical variation is fascinating. Makes you wonder about environmental triggers in those high prevalence areas.
Definitely. Or maybe specific genetic factors within those populations.
Okay. So let's get back to the patient experience.
Yep.
What are the actual clinical features? What might someone notice?
The features are incredibly diverse. That's the challenge, right? But we can break it down by system.
Let's start with the lungs, since that's most common.
Okay, respiratory. Very common. Maybe 90% of cases have lung involvement. Patients often get a persistent dry cough. Shortness of breath is key, especially with exertion, what we call exertional dyspnea.
Breathless when moving around.
Exactly. Also chest pain sometimes, maybe some wheezing.
Sounds like fairly typical lung symptoms. What about more general body-wide symptoms?
Yeah, constitutional symptoms are common too. Things like fever, night sweats, just feeling generally unwell malaise. Fatigue can be a really big one, quite debilitating, and unintentional weight loss.
Fatigue sounds significant. What about the skin?
Skin manifestations are quite common. Various rashes, nodules under the skin. We mentioned erythema nodosum earlier, those tender red bumps on the shins, part of Lofgren's.
Right.
And there's another specific one called lupus pernio. It's less common, but pretty characteristic.
Lupus brunio.
Yeah, it typically affects the nose, cheeks, ears, gives them a sort of purplish, swollen look. If you see that, you strongly suspect sarcoidosis. Think lupus pernio affecting the nose, ears, cheeks.
Good visual cue. Okay. Eyes next.
Absolutely. Eye involvement needs checking. Granulomatous uveitis is common inflammation inside the eye. Causes pain, redness, blurred vision.
Ovaries.
Also, dry eyes are frequent, and later on, glaucoma can develop, which affects the optic nerve.
And the nervous system, neurosarcoidosis.
Yes, neurosarcoidosis. That can cause a huge range of symptoms depending on where the granulomas are. Things like Bell's palsy facial weakness,
Okay.
lymphocytic meningitis, which is inflammation around the brain, even hormonal issues like diabetes insipidus, and lots of other neurological deficits.
It really does seem to touch almost every system. What about the heart?
Cardiac involvement is less common than lung, maybe 5% or so clinically, but it can be very serious when it happens.
How so?
It can lead to cardiomyopathy, a weakened heart muscle, arrhythmias, irregular heartbeats, even heart failure, sometimes presenting quite young.
Serious stuff. And enlarged lymph nodes, lymphadenopathy.
Very common. Often the first sign picked up on a chest x-ray, those bilateral Hiller nodes. But you can get enlarged nodes elsewhere too, armpits, neck, groin, even salivary glands can get swollen.
Salivary glands too. What about the liver?
Liver involvement is actually quite common if you look closely, like on biopsies, but it usually doesn't cause major symptoms. Maybe some abnormal liver function tests, perhaps mild hepatitis in less than 10%.
Okay. And you mentioned calcium levels earlier, or hypercalcemia.
Yes, high calcium in the blood hypercalcemia or high calcium in the urine hypercalciuria. It happens in maybe 10–15% of patients.
Why does that happen?
It seems the granulomas themselves can produce an enzyme that activates vitamin D, leading to increased calcium absorption.
Oh.
Okay.
And that causes problems.
It can. Kidney stones are a risk. Also, neuropsychiatric symptoms like confusion or mood changes, abdominal pain, bone pain sometimes.
Wow. Joints and muscles too.
Frequently. Inflammatory arthritis, so joint pain and swelling around the joints, periarticular swelling. Tenosynovitis, which is inflammation of tendon sheaths. Dactylitis, swollen fingers or toes, sometimes called sausage digits.
Sausage digits. Memorable.
Also osteopenia, so lower bone density. And myopathy, meaning muscle weakness.
It's an incredibly broad spectrum.
Any other systems. Just briefly, bone marrow can be involved, maybe causing anemia or affecting immune cell counts. The spleen can enlarge, causing discomfort. Upper respiratory tract nosebleeds, stuffy nose, and as I said, salivary glands, facial swelling, pain, dry mouth.
Okay, so the presentation really varies. You mentioned ethnicity influencing things.
Yeah, there are some observed trends. For example, Black patients seem more likely to develop more severe chronic pulmonary disease, whereas white patients might be more likely to present with that acute Lofgren syndrome, which often goes into remission within a couple of years.
And not always.
Not always. A significant minority, maybe 10–30% across different groups, develop a chronic progressive pattern. So a thorough clinical exam is vital, checking skin, eyes, joints, nodes, heart, lungs, nerves, everything.
Makes sense.
Yeah.
Given all these possibilities, the investigations must be pretty comprehensive. What tests do doctors use?
They really are. We can group them. Sometimes, if the picture is classic, like Lofgren's, a clinical diagnosis is possible without needing a biopsy.
But usually you need tests.
Usually, yes. Blood tests are a starting point. A full blood count, or FBC, might show low white cells, high eosinophils, low lymphocytes, maybe anemia.
Okay.
ESR, the erythrocyte sedimentation rate, is a general marker of inflammation, often elevated. Kidney function tests, UNEs, creatinine. Serum calcium, as we discussed, might be high. Liver function tests, LFTs, can be abnormal. And that serum ACE level, again, often elevated, especially in active disease and sometimes useful for monitoring.
So bloods give clues about inflammation and organ function. What about looking inside the chest? Imaging.
Imaging is crucial, especially chest imaging. A plain chest x-ray is often the first step. It might show those typical enlarged lymph nodes in the middle of the chest, bilateral hilar or peritracheal lymphadenopathy.
Okay.
If the x-ray looks normal but we still suspect lung involvement, a high-resolution CT scan, HRCT, is much better at picking up subtle interstitial lung disease inflammation or scarring in the lung tissue itself.
More detail from the CT.
Exactly. We even have a staging system based on the chest X-ray, from stage 0, which is normal, up to stage 4, which indicates advanced fibrosis or scarring.
Stages 0 to 5. And lung function tests.
Lung function tests, or PFTs, are important too. In more severe disease, they might show a restrictive pattern, meaning the lungs can't hold as much air as they should, sometimes called shrinking lung syndrome in severe cases.
Shrinking lung. And ECG for the heart.
Yes, an ECG is important to screen for any heart rhythm problems, which can happen if sarcoidosis affects the heart's electrical system, or sometimes just due to the high calcium levels.
Right. Any tests specifically for the lungs?
Yes, for pulmonary sarcoidosis, we can do a bronchoalveolar lavage, or BAL.
Lung wash?
Sort of, yeah. Fluid is washed into a small part of a lung during a bronchoscopy, then collected. In sarcoidosis, the fluid often shows increased lymphocytes and characteristically a raised ratio of CD4 to CD8 cells. Think CD4 up, CD8 down.
CD4 down, CD8 ratio. Got it. Biopsies.
A transbronchial biopsy, taking tiny samples from the airways via bronchoscopy, is often done. Finding those non-caseating granulomas is really helpful for diagnosis.
Non-caseating again.
Key feature. There are newer techniques too, like endosonographic nodal aspiration. Using ultrasound during endoscopy to biopsy chest lymph nodes sometimes gets a better sample.
Okay. Any other scans?
An FDG-PET scan can be useful. It shows areas of active inflammation throughout the body. It can help assess severity, predict if lung disease might worsen, and track response to treatment.
PET scans for inflammation. What about gallium scans or biopsies from elsewhere?
Gallium scanning isn't used as much now, but it can show inflammation outside the lungs and sometimes gives a characteristic lambda pattern. If there are skin lesions or swollen lymph nodes you can easily reach, biopsying those is a good way to confirm non-caseating granulomas.
Makes sense to biopsy what's accessible.
Exactly. And because eye involvement is common and can be serious, everyone newly diagnosed should have a thorough eye exam by an ophthalmologist.
Good point. I see Cavine's test mentioned.
PAVOMS. It's mostly historical now. Involved injecting material from sarcoid tissue and seeing if a granuloma formed. Less used due to safety concerns, and it takes weeks for results.
Okay, so mostly historical, right? We have a diagnosis. How is sarcoidosis managed? Is treatment always needed?
Not always. Maybe about half of patients will need systemic therapy at some point.
Okay, and what's the first step usually?
First-line treatment is typically oral glucocorticoids, steroids like prednisolone. They're effective at reducing inflammation.
But steroids have side effects, right?
They definitely do, especially long-term or at high doses. Weight gain, mood changes, diabetes risk, bone thinning. So the goal is always the lowest effective dose for the shortest time possible.
Makes sense. What if steroids aren't enough or cause problems?
Then we move to second-line agents. These are often anti-metabolites or immunosuppressants like methotrexate, azathioprine, leflunomide, or mycophenolate mofetil. They help reduce the need for steroids.
Steroid-sparing agents.
Exactly. And for really severe or refractory cases, ones that don't respond well, there are third-line options.
Like biologics.
Yes, anti-TNF monoclonal antibodies, things like infliximab or adalimumab, they target specific inflammatory pathways, but they also have potential side effects and toxicities and don't work for everyone. Sometimes other agents like rituximab are considered too.
So a tiered approach. What are the main goals of treatment?
The main goals are really threefold. Relieve symptoms, preserve organ function, and prevent long-term complications and irreversible damage.
And the specific treatment depends on?
It heavily depends on which organs are involved, how severe the involvement is, and whether it's impacting the patient's quality of life or threatening organ function.
Yeah.
And regular monitoring is absolutely key. Blood tests, imaging, function tests to see if treatment's working and adjust as needed.
Right. Does treatment differ much by organ? Like lungs versus eyes?
Yes, definitely. For symptomatic pulmonary disease, oral steroids are the usual starting point. We also need to think about bone protection bisphosphonates if they're on long-term steroids. Interestingly, inhaled steroids haven't really panned out for sarcoid lung disease.
Okay. What about outside the lungs?
For most extrapulmonary involvement, steroids are again the initial go-to. For cardiac sarcoidosis, its complex needs joint management between sarcoid specialists and cardiologists, managing the inflammation and the heart issues.
And the eyes?
Eye treatment varies a lot. Simple anterior uveitis might just need steroid eye drops. More severe or posterior inflammation needs oral steroids, sometimes even injections into the eye. If long-term steroids are needed, we might add a steroid-sparing agent to reduce risks like cataracts or glaucoma. Acute optic nerve inflammation might need high-dose IV steroids initially.
Wow, very specific. Neurosarcoidosis. Skin, joints.
Sarcoidosis usually starts with fairly high-dose oral steroids, maybe 40-80 milligrams daily. Skin disease is often treated for symptoms or cosmetic reasons, starting with steroids, but localized patches might get injections or creams. Severe skin stuff like lupus pernio might need stronger drugs like infliximab. For joints, we often try NSAIDs first before moving to steroids or other immunosuppressants.
It really sounds like personalized medicine in action. How does the UK approach generally look?
It really emphasizes that tailoring. Considering if it might resolve on its own first, especially early on. Using oral prednisolone or sometimes inhaled budesonide for lung symptoms. Using those alternatives like methotrexate or azathioprine when needed. Steroids for skin, eye, nerve involvement. It's all about the individual patient's picture.
And non-drug options.
For the most severe cases, end-stage lung disease, stage 4 with respiratory failure, lung transplantation is an option. Sarcoidosis is actually the second most common reason for a lung transplant among interstitial lung diseases.
Lung transplant. Okay. So outcomes can clearly vary a lot. What's the general prognosis?
It's highly variable, as you say. Some people have spontaneous remission, often within a few years, especially those with Lofgren's.
That's good news for some.
Yes, but others develop a chronic progressive course. About 20%, maybe 1 in 5, end up with permanent symptoms because of irreversible fibrosis or scarring, mainly in the lungs.
Permanent damage. And does it affect lifespan?
Unfortunately, yes. The overall survival rate for people with sarcoidosis is somewhat lower than the general population.
That's tough.
Yeah.
What's the main cause of premature death?
The most common reason is advanced pulmonary fibrosis leading to respiratory failure. That's the biggest driver. Less often, it can be due to severe heart involvement, CNS problems, or liver failure.
And specific lung complications.
Yeah. In advanced lung disease, things like pulmonary hypertension, high pressure in the lung arteries, or severe bleeding from fungal balls, called aspergillomas, that can grow in damaged lung cavities, can be fatal. So long-term complications can definitely reduce life expectancy.
Are there any preventative measures patients can take?
Well, we can't prevent it starting since we don't know the cause, but once diagnosed, things like the annual flu jab are important to prevent respiratory infections. Osteoporosis prevention is key for anyone on long-term steroids, calcium, vitamin D, maybe bisphosphonates. Patient education is vital too, so they know to report symptoms of eye trouble or heart issues early.
Get early treatment for complications.
Exactly, and smoking cessation is always advised, although the direct evidence for it impacting sarcoidosis progression isn't super strong. It's generally bad for lungs anyway.
Always good advice. Okay, last section. Potential complications. What can go wrong long-term?
Again, it reflects the systemic nature. Lungs, increased risk of infections, blood clots, pulmonary embolism, that progressive fibrosis, pulmonary hypertension.
Okay, heart, eyes, skin.
Heart, arrhythmias, heart failure, eyes. Chronic uveitis, potential sight loss. Skin, chronic, sometimes disfiguring skin disease.
Liver, nervous system.
Liver involvement is common, but rarely causes major failure. Nervous system, nerve damage, cognitive issues, stroke risk would potentially increase.
Any others?
ENT issues like salivary gland problems, nosebleeds, lymphatic issues. There's a slightly increased risk of lymphoma down the line, hypercalcemia leading to kidney stones, joint damage from chronic arthritis.
So a wide range of potential issues impacting function and quality of life.
Absolutely. Complications can range from manageable dysfunction to genuinely life-threatening conditions. It underscores why ongoing monitoring and management are so important.
So to wrap up, sarcoidosis is this complex, multi-system inflammatory condition. Hugely varied in how it presents and how it progresses.
Exactly. A real challenge for diagnosis and management because there's no single test and it can affect so many different parts of the body.
It really highlights the mysteries still remaining in understanding our immune system.
It does. And the ongoing research trying to unravel those causes and find even better, more targeted treatments is crucial.
Absolutely. Well, this has been a really thorough deep dive for everyone listening who wants more resources or revision materials, especially for exams like the MSRA. Do check out PathMSRA.com.
And freemsra.com also has some great free resources available.
Excellent. Thanks for joining us on the deep dive today.